So as I said, no more talking. When you're done, all I want you to do is sign off of your phones and sign immediately back on your laptops, your computers. Make sure you're on mute. That will give me your attendance. Okay. So that shows me from when you came, and it's continuous, and I'll have a couple minutes to upload and get you whatever is okay, but it's not like a difference of an hour in between signing off and signing back on. Again, I'll give you thumbs up, thumbs down, or one of those medium type things. You can send me in chat box, or you can send me a message in Canvas. I'm watching both of those because, I'll tell you where you are in your exam. And again, I'll go over it with anybody. So let's just take a deep breath. Let's take a moment. Breathe in and just breathe out. Get all of that anxiety gone. Read the questions carefully and do not overthink. There are some answers that, yes, are that easy, okay? So take your time. This is not a speed game, and I wish you all good luck. Now, let me give you your codes. Remember, be back at 4:20. Remember that I will put this code also, I'm going to put it into your chat box so that you have it there. So let's start, everybody. Any questions before we go? We're all good. We're all going to get A's, right? We wish, right? Okay, here we go. Number 8, capitals A, capital Q, capital U as an umbrella, another U as umbrella, and a capital C. Again, number 8, capital A, capital Q, capital U, capital U, capital C. If anybody needs a resume code, anything, put it in the chat and I will get you a number. Give me the number it's giving you and I will give you a resume code.
Can you say that one more time, the password?
It's in the chat box. It is number 8, capital A, capital Q, capital U, capital U, capital C. And put your camera where it needs to go. All right, I'm signing off. No more talking. I believe we are all done. Am I correct? Linda, you're finished, correct? Put your thumb up. Okay, good. All right, I was just making sure everything was done before I spoke. So I've given you some of you the yes, no, you did good, real good. You need to come see me. Make sure that if you did not get your 78, please come visit me. Because remember, you're going to see these questions some way or another, whether it's going to be on your HESI or NCLEX. So if you don't understand it now, you're not going to understand it tomorrow because we didn't review it. Okay. So I just want you guys to do the best you can do. And sometimes that's just meeting with me. So let's go ahead. We're going to do the PowerPoint.
I do
Like
have one question though. Do
Sure.
you itemize it and like look at what questions are wrong? You know, like if everybody got this question wrong, you know?
Absolutely. It's what we call an item analysis. We look at the questions, how many got it right, how many got it wrong. We look at many different variables with it. So we will make sure that your exam was a fair exam. Okay, on all levels. So that's one thing I will take care of. So don't worry.
Thank you.
Another thing is quiz 2 was a bear for many of you, and many of you didn't do the scores that you wanted. I am looking at that quiz also on Saturday with the pediatric team. So just to let you know, I do have your backs. I'm looking out for you to get you what you deserve. Excuse me. Its good old voice is going to be the death of me, I think. All right, week 4. We're going to be doing the PowerPoint. And this is a week of some interesting stuff. So let's go over it. I'm going to try to go over this, not go crazy in depth, because I'd like to get us out of here at least by about 5:15. All right. So let's go with chapter 37, 37, 38, 39. Cognitive impairment is basically when you're not doing all those developmental levels where you should be. Something has held you back, whether a syndrome or whether it was nutrition, right? We know that that can cause it too. And we usually can figure it out. Family members will notice, or many times it's nurses, which is a great thing because we do have input and we do see patients, children, more than physicians do. So we have more of an insight. Now, there's different levels of functioning, as we call it. And there is like this little thing that we go through. When they can do things, they can't do things. We look up and we try to figure out the IQ and see their ability, if they are going to be trainable or educatable. So when we get the numbers and we see 85%, which is mildly cognitive impaired, we know that we can educate these children. Because children become adults, right? And these adults at times can't be put out into the community and live on their own with somebody watching over them. They even go to college. There's many colleges today where they do have programs for like Down syndrome children, and they have one class at a time. They usually have somebody that goes with them to make sure that they're understanding. So I think that's great that, we give them everything they could or want to be. And then we have those that are just trainable. We can't educate them. Sure, they learn things, etc. But in the end, we need to teach them how to do things for themselves. It could be trainable as in when I go to my grocery store, I've got my baggage packers and I know I'm going to go find Edward. I'm always going to go to his line because he does a great job. And I always get my hug when I'm done. And I give him $2 and I say, shh, don't tell anybody. Go get yourself a soda later on. And he's like, well, I can't. I'm like, well, shh, I'll put it in your pocket. Nobody will know. So I do appreciate them when they, especially my Edward. So there are different levels. And here we go into them: mild, moderate, severe, profound, just for you to read over when you look at your PowerPoint. Now, what are some things that can cause cognitive impairment? Well, I already said nutrition. Absolutely. Brain doesn't get the fuel, it's not going to run right. Just like a car, you don't put in proper fuel, it's not going to run. Same thing. It could be during pregnancy, it could be during delivery, or it could be other things. Could be trauma when we're trying to get the child out. They don't squeeze through the canal, then we have to push them back up and then do a C-section. Those things can cause it. Or it could be that infant who fell off that changing table onto the floor, hit the head. Those are sort of traumas that do occur. It could be an infection, brain disease, an abnormality. Brains are, mostly born, quote, normal brains, but it's amazing that more are not normal the way they should be. We know prematurity. You have a young, premature infant. Their brains are fragile and they're apt to have what we call intraventricular hemorrhages or brain bleeds. And they're on the level of 1 to 4. And that brain gets irritated by the blood. And we know that blood takes up space. So something's going to happen. Now, I've seen grade 4 bleeds just be a little hyperactive or maybe need a little extra help in schooling, but do really well. So it doesn't always mean there's going to be big delays, but it puts you on the alert that you might need to give help. And of course, psychiatric disorders and of course, environment, there's a lot of pollution, those can cause it. As I have said all along, you see a problem with cognitive development, the biggest thing is early intervention. Children that are given early intervention do better than you can imagine. They catch up extremely quick. Now, some children may not be on a quote normal level than other children. But, you see these children, they have these little things in front of them, toys, like this boy up top or girl, top right, or the puppy. She's got a remote to make it move. Now, that's a big deal for this child. Or maybe it's a video game or teaching them things that we didn't let them do years ago. I mean, years ago, we had children with cognitive impairment. We fed them, we turned them, we bathed them, got them out of bed, but we really didn't do physical therapy, occupational therapy, speech therapy. They went to school. Today they go to school and they're taught things. My little Jonathan at the daycare where I did my clinicals with the students here in Florida, little Jonathan, spastic cerebral palsy, would see me, his face would light up, his big white teeth, and he would just go spastic, like, because he knew I was going to kiss him. Well, that child can talk to me through a pad because he's nonverbal. He also knows colors and shapes and words. And why? He had early intervention from birth. He's been going to this daycare. He knows the routine. So it does work. So we get that optimum development. And then when he reaches that, we do more. Now, what is important for these children with cognitive delays? Now, not all of them can talk like Jonathan, but he has a pad. It's this little pad given by the March of Dimes, and he can push something and he can tell us what he wants. Maybe he needs to be changed, or maybe he wants to see the TV, or maybe he wants a hug. All of these things he can express. Can you imagine the decrease in frustration? Can you imagine when he couldn't talk? Or those children before him that didn't have that ability. So today they can express their things. We know that they need a way to be involved with the group. Very important. Now, just because a child has cognitive delays like autistic children, Down's children, it does not mean they're allowed to misbehave. They are also given the same rules. For instance, when this daycare, they come in by school bus, they pick them up and they go bring them to the school. They come in with their backpacks. They take their backpack off, put it in their cubby, and they sit down and wait for vital signs. And if they think they're going to get up and just go run and play, they call them back. Now sit down till I'm ready. And they make them wait. And they do. And it's quite impressive. There's one Down's autistic child, if you could imagine. And that kid knows exactly what to do. We also know that as they get older, And for instance, that young Downs child who's cognitively delayed, of course, and it's a girl. Can you imagine? She could be abused sexually if she didn't have a really good concrete code of sexual ethics, like what is good touch, what's bad touch, because they don't know. So teaching, and they work well. Now, cognitive impairment, as I said, there's ways to prevent it, some ways we can't. We know things like smoking during pregnancy, not being around rubella when you're pregnant, folic acid, that we're taught in pharmacology to prevent those neural tube deficits. All of these things can help. Now, I've mentioned it a couple times. Down syndrome, the most common of all chromosome abnormalities. Now, there's not just one Down syndrome. Now, you think of Down syndrome, you think of chromosome 21. Well, that's the least severe of all of them. There's 21, 18, 15, 11, and 9, believe it or not. And when you get to 9, you're going to have cardiac abnormalities, physical abnormalities, and they're really severe. And usually the projection of life is not good. And I've seen 1 9 in my career, had half a heart, could not breathe without a ventilator, and had multiple, like 2 fingers, 1 toes, was blind. So they are quite severe at that point. We know one of the big things is maternal age and Downs. We know that that's one of the things we look at in your chances for that older pregnant woman. Now, what does a kid look like? I think they're the most adorable children there are. They've got these beautiful faces, these big smiles. We know they got this flat nose. That bridge is small, and it collects a lot of mucus in there. That's why they're always with upper respiratory infections, because of their noses. But they've got the Simian crest on their crease on their palms of their hands and on their feet. You see the almond eyes, and of course you always see a big tongue. And they can take their legs and put them both behind their head. They are so flexible. The thing to worry about with Down's children is many of them have congenital heart disease. It could be just as simple as a hole between ventricles as a ventricular septal defect, or it could be something a little bit more, a truncus or an AV canal. And we don't go over those in detail, but it just means the valves aren't hooked up right and you've got a backflow going on all over. Another thing they need to be checked for is thyroid disease. So these children will be getting their thyroid hormones about once a year to make sure their thyroid is good and they have a higher chance of leukemia. Here is the big picture of Downs. You can see what they look like. They're the most lovable children. Probably the reason why I like Pete so much is as a teenager, I used to go to the YMCA and I was, the junior, senior lifeguard, water safety aide, that. And I used to teach these children how to swim. And these children have so much trust in you. And, when you got one of those kids to dive in head first, when they were afraid of it at the beginning of, the class, or you get on your back and you just put your hands out and they have to swim into the deep end. That's a huge thing. And it gives me a lot of pleasure just to even remember about those things and working with those children because they are so lovable. Now, all of these congenital abnormalities can be fixed. We always look at the hearing. We also look at their vision like any other children. And of course, we're going to be checking those thyroids. And we're also going to make sure that they get the therapies they need to be the best that they can be, right? I mean, if this kid puts their feet over the head all the time, he could dislocate his hips. And that could cause another gamut of issues. So need to tell them, yeah, that's cute, but don't do it too much because they'll pop out. Also, parents do need genetic counseling after a Down's child to see the chances of another. Now, Fragile X is similar to Down's. It's the second most common. It looks like Down's, but there's some facial abnormalities. You'll see that long jaw, the big ears. You're going to see the testicles are going to be huge. The problem with these guys are they are more aggressive. They're more autistic, very, very sensitive to taste, sounds, touch, extremely hyperactive. And these children were going to need medications. Down's children generally do not, but they have a normal lifespan. So planning for their future is important. Making sure who's going to take care of them when mom and dad aren't there, right? And again, genetic counseling. Now, hearing impairment is another thing that can happen to children. We do hearing tests before they go home today. So we know that they're hearing, but it doesn't mean that with frequent ear infections or something, they could lose hearing. Usually the first thing you hear with a hearing loss is their speech is not as clear. So if you can't hear, you can't pronunciate well. So any child with speech delay, number one thing you're going to do, check the hearing, make sure that they hear properly. Now, hearing could be mild to profound, and it could be many things. It could be their ears not shaped right. It could be that premature child. Remember, brain bleeds and all these things that go on. Now, oxygen is great, but it can affect the ears. Also, remember the talk about aminoglycosides in pharmacology, like vancomycin, the CINs. What do you get for toxicity? Ototoxicity, right? You can burn your ears, as in you're not going to be able to hear well because of drug administration. And then hypoxemia at any stage, whether it's at birth, after birth, an hypoxic episode can cause it. And that also is part of infections that can occur with premature and cerebral palsy. Now, sometimes it's just the outer ear, and they're going to need a hearing aid and they do okay, but they've got the proper stuff going on there to be able to hear. We do measure it, it's by decibels. Now, sometimes it's those chronic ear infections. So that's why we have to make sure parents take the medicine till it's done, not until the child feels better, and not to share it with the brother who also has an ear infection, because that's what many parents I've seen do. Now, if they're having chronic ear infections, they're probably going to have tubes put in. Now, I had tubes put in about 6 years ago. I had it put in the doctor's office, and under no anesthesia, anything, they put some numbing stuff there, and they made a little hole, I heard, by the scalpel. And then I felt them take a little suction catheter, put it in there and go and suction the mucus out of my ear and put the tube in. And when I got up, I was dizzy. It is doable without anesthesia. A kid won't sit there for it. That's why they're knocked out for a very brief amount of time. Now, hearing aids can be used if we've done everything, right? Cochlear implants. Have you ever seen one of those things on Facebook about a kid just hearing for the first time? Well, I actually saw that. I was going to the University of Miami to this ear specialist and sinus specialist because I went through, 5 or 6 sinus surgeries. It was horrible. That was what was going on. And in the next room was a little boy, and they put on this cochlear implant. And I actually said, I heard him say, sort of garbled, but I hear you, Mom. And I was like to my husband, do you believe that kid finally heard for the first time? They had to be, 4 or 5 years old if they're saying those things. So it is emotional because I was crying. I don't know if the mother was, but I was, because I thought it was pretty neat. Now, hearing as an infant, what do you see? Well, hopefully we catch it at that newborn with those hearing tests. But if you're making noises, smacking real hard next to them, they're not moving, they're not hearing, okay? We know that if they're not speaking mama, dada at all, nothing, by a year old, something is going on. So remember, speech and hearing are connected. If you're not hearing, you're not going to speak. How do you know what to say? You've not been taught, right? You haven't heard it. So also, there's stuff going around, they don't hear it, or also you're calling them, they're not answering. I mean, this is how you find out when an animal doesn't hear, right? You're calling their name, they don't answer, no answer. And then you figure it out. They're just deaf because they can. Now, here's a picture of a cochlear implant. You just connect them to the scalp, and it's a little thing that they turn up and down, and it works great. Now, when you're taking a kid and getting them home with these informations, make sure they know how to use the equipment, okay? Also, because they haven't learned how to communicate what they want yet, those picture words are great. Like if they want milk, they want to go to bathroom, they want to go outside, they want to go to bed, they read a book, pictures of it can help them. And then, of course, you as a parent would be also saying the words and having that child trying to repeat it. Definitely working with a child life specialist. As I said, child life specialists are the most educated people to play with kids, and they have been taught how to play on their developmental level. They go all the way up to a PhD in child specialist. They don't make a lot of money though.
That's
It's
like a kind of cool job though, just playing with kids all day.
Hey, I did it as a nurse, but of course I had other stuff. But do you realize some of them made 30,000 a year with a master's degree? The minimum is a bachelor degree. So many of them do the combination RN with that or occupational therapy with it. They do different things so they can make, a salary, that sustains life, of course. Remember to prevent hearing. A lot of it is noise, taking a kid to a concert next to a speaker or at home, the music too loud, all of those things can do it. And of course, those drugs, like I said, those ones with the CIN, aminoglucosides, they will burn the ears and they won't be able to hear because now you've destroyed the hearing mechanism of the ear. And of course, syphilis, rubella, some mothers have syphilis at birth, but it went undiagnosed. And this could have been passed to the child, and it can affect the hearing. So we need to look at all those things. And, that American Idol, I remember a couple years back, this girl, great voice, she got second, not first, and I was so upset. But she had her little 8-month-old kid there in the audience, but they had ear buds on her head, to cover the noise. And I was so pleased to see that they took care of the child with the mother there. Now, vision. Now, we know that there's partial vision, full sighting, and there's also legally blind. And we know with vision, it's a common problem in childhood. There's many things that we can do, and we'll go into that. We know the Snellen chart's 20 feet away. And if you can't see good at 20 feet, and let's say you have a child whose vision is poor, well, at this point, we need to tell the doctor because maybe they do need glasses, or maybe there's corrective surgery, something's going on. We want a kid to be able to see. They can't see, they can't learn. And remember, children are learning, it's important. We have myopia, nearsighted. Hyperopia is farsighted. And it's like the opposite what you think. Nearsighted, you can't see far. It's like, why did they do that? Why didn't they name it the other way, right? So if you're farsighted, you can't see near. Now, I can see a flea 100 miles away. I can see it. I cannot see my fingernails in front of my face. So you'll have different things, and as you get older, they'll change. Here's some different conditions. Now, strabismus is where your eyes are sort of trying to focus together. So you sort of see them like wiggling, right? And the way that we're going to treat this is usually with corrective lenses. Now, amblyopia is what we call a lazy eye. All of a sudden, the eye will go the outwards or inwards. How do we fix that? Well, you saw the picture earlier of this child with a patch on the eye. Well, you want to make that lazy eye work. Say, lazy eye, I don't care, you need to work. Let's patch the good eye. Now you have to work. And what it does, it strengthens the muscles. And then usually that's all they need for it. Kids are always sticking something in their eye, falling down, pencils, straws, falling on the ground, pine cones, gravel, or they're outside, a lawnmower in the eye. I mean, kids are always getting it. Now remember, if we can see something floating, you take a tissue, get it out. If it's sticking out, you need to stop. Put shields, what we call Fox shields. They're hard, and you put them on and get them to a pediatric ophthalmologist or a pediatric emergency room, and they're going to need to take care of it. So that prevents it from getting any further injury. Now, there's many reasons why you can get eye issues. Now, prematurity, most of the times their lungs are immature, and most of the time they need oxygen because their lungs aren't working right? Oxygen can cause problems with the retinas. So it's the retinopathy of the premature is what it's called. And the retinas get damaged, the ROP or retinopathy of the prematurity. Now, there's surgery they can do to fix it, but it's because of the oxygen going up and down and up and down, and it can hurt eyes. We've learned that, okay, a kid starts to have a lower saturations, turn up the oxygen slower and wait, be patient. Just don't go from 25% to 100%. That's when you hurt the eyes. Also, eye infections can cause it. And then also sickle cell. Well, there's little blood vessels there, right? You could have a sickle attack in the eyes. Also, JRA, rheumatoid arthritis, like me and my vocal cords, it's also in the eyes. These are places that can get inflamed and cause vision issues. And then Tay-Sachs has to do with fat accumulation in the eyes, etc. So there's many different disorders that can cause problems. Now, kids.
Can it be genetics?
Yes, it can. Yes, it can. Absolutely. Absolutely. Now, conjunctivitis is an infection, an itis, an infection of the eye. And these kids get goopy, oopy stuff that drains. And they always take the hand from this eye to put it to this eye. Usually you're not going to see just one because that's just kids. We clean it from the inside away, just with soap, little bit of soap, not enough to irritate, and water, and just get it out, and we'll put the ointments on there. And it does help. Again, make sure these parents know about it's contagious, to wash their hands. And another thing through the years that I have taught them is change the pillowcase every night, because the old goop is on there from last night. And many nurses don't think about this, and parents don't. So reminding them can help them from getting or continuing this eye infection.
Stuffed animals too.
Oh, absolutely. Throw them in the washer dryer. Yes, great point. But it does, because, in the face, and it's everywhere. And what do kids do with their animals? They share them. So you got other kids, guess what? Everybody's going to get it if you're not careful. So you have to teach them all how to wash hands and not to share. Thank you. That was a great comment. Now, assessing. When you're looking at a child, you're going to see things like lack of depth perception, unable to put a block on top of stuff, or they can't see where a toy is. Like, where did this go? Where did that go? Because kids will ask, they can't find it. Also, when you see infants, you might see their eyes twitching, right? Trying to focus. It's like it crosses midline back and forth. Or they're not looking at you because they can't see. We know we're going to check them as they get older. Now, be very careful. If you're doing a check with a light on a pupil and it doesn't react, you need to tell somebody right away. Something's going on, and it could be serious, like a brain tumor, or maybe increasing intracranial pressure due to whatever the consequence. So you're going to take care of a kid, minimal eyesight, barely sees. Well, number one, any infant, we're going to always promote that parent-child attachment. I've had kid cleft lips, cleft mouth, that sort of look dysmorphic, and it's hard for parents. So I'll wrap them up, sit them down. Here's your child, hug them, and I'll mention, oh my goodness, look at that hair. They've got such beautiful black curly hair. Or, wow, look at those cheeks. I just want to pinch them. I get them away from focusing on what was wrong, right? Another thing, with children, you got to remember if they can't see, large print, sit in the front of the class, giving them extra time, and trying to keep them independent. Their rooms at home should be in the same way. Don't just go in there and change the organization. They're going to go in and fall, trip over something. That goes with the hospital room. Let the child know where everything is and make sure there's a sign. Child is blind, do not move furniture. Housekeeping will come in, right? And all of a sudden there's a bedside table in the middle of it and they're going to bop in it and they can hurt themselves. And again, always, always, always encourage that independence with these children. How do we prevent visual problems? Well, I told you about the oxygen. Be careful with it. Make sure they have rubella immunizations. And then if they're outside playing and it's the lawnmower, they should know not to be there because it can cause problems. And if something happens with their eye, immediately go to mom. Don't rub, because they could scratch their cornea up. And always we're going to do checking. Hearing and visual, as I said, you've got to be careful with these children. Make sure that they have a way to express themselves. They can finger spell, they can lip read. There's so many things children can do that do not have problems. They can't hear well or they can't see well. Now, retinoblastoma is a tumor. It is very cancerous. There's not many. I've seen one in my career. I believe she was like 8 months old. This poor little girl, I looked at him and you see like the old, when you took a picture with a flash, your pupils turn white. One of the other things you'll see is, have you ever gone in your backyard at night and you turn on a light and you'll see a cat, a dog, a deer, a bear, and you see those shiny eyes? It's the same look that you will see with these children. And they have to remove the eye. They do radiation, they do chemo, and they do surgery. And hopefully it hasn't metastasized and we can, they'll get a fake eye that they put in there. And I remember a kid in high school, apparently this is what he had. He used to take out his eyeball and roll it around on the desk, put it in his mouth, get it wet and stick it back in just to gross everybody out, especially the girls in high school. I remember I was in 9th grade. He's traumatized me for life.
So they always have to, like the eye is going to get removed?
The eye has to come out. The whole retina has to come out or it will spread. The whole boundaries, everything. Yes, yes. It's better to have a fake eye and to be alive. But yes, I know it's a hard thing for any parent to think about. Now, autism. Now, autism is more common in boys than girls. We usually do not diagnose till they're about 2 to 3 years old. We may see symptoms of it, but we're not going to see those, diagnose them till 2 to 3, because then they can talk. So these children, it could be due to anything. We're not sure. It could be genetics. It could be due to prematurity. Could be due to, meningitis or anything. They really, really don't know. Now, what do you see with an autistic child? Well, these children will play alone. You'll call their name, they're not going to answer. They do not look at you. They do not like to be touched. And then cognitively, they're delayed. They're not going to be able to do the fine motor skills and the gross motor that a child of the same age would do. And they're not going to have the same language. You're lucky if you have one word out of them. Instead of mama, it might be ma, da, and that's about it. And a lot of times they will scream instead of trying to verbalize. How do we take care of them? Well, early intervention. I mean, I told you about that poor little kid, this little boy, his name was David. He was, I think, 5 years old when I met him, 4 or 5. He was Down's autistic. And this kid would come in, go sit down, wait for his vital signs, then go in the corner, and he would do what we call repetitive behaviors. He would find a bunch of toys, and let's say he found a truck. He'd take the truck and put it on the chair. And then he would find a little car, put it on top of the truck. And then he'd find a stuffed animal and put it on the other side. And then he would cover it with a book. Then he would take the book off, then he'd take the bear off, he'd take the car off, and take the truck and put it on the ground. Repeat, 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 repeat. This gives them comfort, okay? So that's the way that you would see a child. We know it's structured behavior. It must be routine, everything the same way. And we're not going to accept any bad behaviors. They will get a consequence. Remember, families need support. They need all of the information you can give them. So the nurse is discussing sexuality with the parents of an adolescent girl with moderate cognitive impairment, like the Downs girl. What should the nurse consider when dealing with this issue?
See,
See,
Yes, absolutely. Again, they need to know what's good and bad, a concrete code of sexual conduct. All right, now getting to the kid hospitalization. How are they going to be? Because we need to know what those behaviors are so that we know, is this the right behavior they're having? What's happening? Now, there's something called separation anxiety. And that's because mom and dad can't always stay there as much as they'd love to. If you're a single parent and working, other kids at home, guess what? You got to work. You have other children. So these children initially are going to be screaming, crying, clinging on the parent. They don't want them to leave. Then it goes into this despair phase. And this is where they stop crying and they look depressed. And they do this regression. They're going to start sucking their finger, or they're going to start, they're having accidents where they've been potty trained. These things will occur. If it continues on into that detachment, it can really have an effect on those children. So as much as possible, we try to keep the parent with the children because we know they'll have emotional long-term problems if we don't have that parent involved. So there's early, late, in an adolescence and the way separation anxiety occurs. So we know early childhood, they want mom and dad there. We know that childhood, when you're talking about 11 up into adolescence, they really are more interested in their peers. They're not as much interested in mom and dad. But when they're sick, they want mom and dad there. Also, remember, if this child has a best friend, you need to make some time or arrangements that they can visit each other. It gives them a sense of control because mom and dad are just good enough, but that best friend is where they can share how they're feeling and it can only help with them because they're in a hospital. They've lost control of their environment, right? They have all of this going on. They're getting stuck with IVs, going to surgery, these scary x-ray procedures. So they don't know how to cope with it. So, Even the adolescents will want mom and dad, but make sure that those adolescents do get time where they can visit with their peers that they need to. Now, you think that hospitalization doesn't affect children that have been there. Well, because a child's had more experience in the hospital and maybe had a bad experience, these are the ones that are going to be more stressed, believe it or not. Don't think because a kid has sickle cell and has been in and out of the hospital forever that they're going to be okay, because these are the ones you have to worry about, okay? So again, the ones that are going to have more problems is when mom and dad don't have control on their kid between 6 to 5 years old, and males are more than females with problems, difficulties. A child with cognitive delays, below average intelligence, and then of course, the one who's in and out of the hospital. Now, today, we know there are more serious, complex problems than ever. We're saving children that used to die years ago. And we know that that has given more special needs children. And it's not just cognitive problems. It could be the equipment they need. You know, it could be a child on peritoneal dialysis, or a child with a trach who needs all that stuff at home. It could be many things. These children in the hospital are sicker than ever. So we need to make sure that this information is taught. Of course, we teach from admission, right? Now, going to a hospital, you usually recover quicker. Remember, this is where diseases are, so chances of infection goes up if you need to be hospitalized. We know that research is always influencing how we take care of children. So the nursing care, I can't even tell you how much changes I've seen. Parents, remember, they're having a hard time with their kid in the hospital too. Don't forget them. And the other person that we forget about is the brother or sister at home, you know, or the cousin, you know, it could be a really close cousin. Remember, we need to involve them somehow. You know, I used to give ribbons to, especially like your cancer kids with no hair and little girls, or my cardiac kids, of course. I would always go to Walmart and buy these rolls of ribbons, and every day, me and the little girl would put our ribbon color on for the day. If there was a sister at home, I would send one home for the little sister. So now they're involved. And we would take a picture, because today, great with the phones, right? Send a picture home to the sister and say, you're getting your ribbon when mommy comes home. And it keeps them involved. And it stops that child in the hospital from worrying. And it stops the child at home from worrying. Get them into the hospital, let them see them. But remember, they need to know what to expect. Sometimes it can be really scary, especially if they're intubated and can't talk, right? So they really need to be prepped. Get them ready for the hospital. Don't do it too early, because they're going to keep being worried for too long. So like the day or two before, let them know we're getting ready to go to the hospital. Let them know what's going on. And of course, try to schedule your time as a parent that you could be there as much as possible. You know, I've said they'll go right into the OR now until they're asleep. So the kid never worries. Always have a schedule. Schedule. I couldn't say how much this helps, especially those toddlers and preschoolers. They need a schedule. They need to know what is coming next. Also, again, your nursing interventions, make it to the point where, you know, mom has to go home for a little bit at this time. That's the time you're going to do a procedure you have to do. Don't wait to separate them while mommy's there, right? We can work around this. Let me see. Also, preparation for the hospital. You know, this little picture down here, I actually think is the hospital where I work. They have this room where it's toys and games and play, and there's Radio Lollipop, and they listen to it on the TV, and they win prizes, and it just makes it fun. It's not a place where there's just pain and going on. They do finger painting, whatever their condition allows them to do. And this is where you're going to see that child life specialist shine. Of course, we also can find out through diversion play, like, this is what the kid's afraid about. And we can let the nurses know and work around it. Again, the family. These are your next ears and eyes in a hospital. Teach them. Let them participate. If they're so sick and all they can do, maybe on a newborn who's open heart surgery, tubes out of everywhere, let them just brush their hair or let them just put socks on their feet, little things. And as you're doing that, you are teaching them to go home. You're also teaching them what they need to tell you if they see something. Parents have helped me with every child I ever took care of, and they will see it quicker than most nurses if they're taught properly. Now, you have hospitals, you have outpatient centers, you have those, just 24-hour things. So they're all different. And why do we use the difference? Well, you have to go in and just get, let's say, a CAT scan. You want an outpatient center. You've got less infection there because you have mostly well children there. You don't see all of the stuff that goes on in the ER. It's cheaper. And you usually can get scheduled quicker too. Isolation is hard, especially if you have that chicken pox and you're on reverse flow air. You can't go out of the room. People are coming in, they're all dressed and gowned up. I mean, it looks like you're in outer space and the kids are scared. So remember, doing things for that kid to alleviate stress, maybe getting them, coloring or something for them to do to get their mind off of it. This nurse on the bottom left is a nurse I worked with for many years. She was an LPN, went on to her RN, got her BSN, and has done really well. She was part of the transport team too. And she took this picture here. Every time I look at it, I laugh because I watched her grow up as a nurse. Now, emergency admissions are the hardest on parents. Your kid is sick. It comes to the point, especially if the kid was hit and it was air flighted into the hospital. You've got a crazy parent, crazy family, and you've got a kid who's scared to death. Make sure if you're going to be that nurse, that primary trauma nurse, which I was many a day, having that kid, let him know what's going on, tell me what's happening, answering questions, trying to keep them calm, keeping the parent involved. Even in this stuff going on, I'll have parents up there by that ever I can fit them in so that the kid knows mommy, daddy's here. Emergencies are difficult. Intensive care, bing, bing, bang, bang, alarms going off, all of these machines, it's scary again. Make sure that the child too understands what's going on and the parents, and get them in just focusing about their kid, not everybody else, because it is overwhelming. So during the first 4 days of hospitalization, Eric, age 18 months, cried inconsolably when his parents left him, and he refused the staff's attention. Now the nurse observes that Eric seems to be settled in and unconcerned about seeing his parents. The nurse should interpret this as what? That means he's already cried. He's already, decided whatever. And now in that depressed mood or that regressive mood, he is now detachment. He's like not, responding to anything around him. And it could be dangerous to get it to there. So child life is going to be with me with this one, getting this kid entertained, doing something. And now some variations. We think that children are little adults. There's so many differences in the care we give. All right, consents. We know if they're 18, they can sign their own if they're cognitively aware. We know the parents have to ask that child for any of those results. We have to find that out. This is in your NCLEX book, always before exams, and your NCLEX. Check this. You're going to see it there, guaranteed. This is one of those things in pediatrics they want you to know. Remember, a parent can give a consent, emancipated minors, or a minor who has their own child can do their own consents, okay? So sometimes in an emergency, no consent's needed. 2 physicians can do it. So knowing your consents is very important, and never give information over the phone, especially if your child is 18. Getting them ready for procedures. We know how to do this, right? Get them on their level developmentally, and then sit there, let them touch and feel and play with the stuff. And they'll be ready because they know what's going on. Again, this is that child life room, going in, touching the stuff with a child life specialist. Always expect success. Don't say, well, sometimes it don't work. The kid don't need to hear that, all right? Distraction is awesome. You know, sometimes I just put on music and starting dancing. I used to have a 3 p.m. routine on a child who was on ECMO, post cardiac surgery. Parents, grandparents, doctors would all come into the room with a mask on because it was an open chest. The heart was right there. And we would sing YMCA, and we YMCA. And what this did, it stopped the parents from focusing on a sick kid. It gave them a moment of going somewhere else. And I'm telling you, that parent today still is in contact with me, and the kid's 25, okay? It does work. It's just part of things nurses do. It helps them relax. And if the kid's older, the kid's gonna do it with me. So things like that. Get them involved, get them distracted, let them know what's going on. Preoperative care, the parents stay with them now. Do you see that physician there with that white liquid behind there? He's giving propofol. The kid's about to go to sleep. And who's right there in front? That's mom. Guess what? Kid's gonna go to sleep, not remember, and mom never left them, right? Because if they know they're going to surgery, they're scared. Now, post-operatively, we're going to treat this kid just like it was an adult. Absolutely. Your blood pressure monitoring, O2 sat monitoring, we're going to be managing pain. Just because as a kid, they still have pain. And making sure that we give appropriate medicines in a timely fashion. Very important. And remember using those non-pharmacological things, as in positioning, ice, heat, giving some acetaminophen in between a narcotic. It works. And of course, we're teaching. As we're talking to the child about things, you're always teaching, and that's part of your discharge. Again, same thing. Now, procedures. We know that these children, we need to be looking at what's going on, and we need to make sure that the child is compliant. I mean, we see this a lot in specialty units, whether it's cardiac or neuro or GI or respiratory. We know if the parent has been following up, doing what they need to do. And sometimes it's the compliance that children suffer from. So being aware of that. Now, if we have a kid who is long-term in bed from whatever condition, they can't get up, they've been in the hospital 2 months, they still get pressure sores, just like adults. So making sure that we do that bed bath as we can. Remember, sometimes they can't be touched that much. Keeping the mouth clean, making sure the teeth, at least with a washcloth, just making sure their teeth don't have all that phlegm on it, right? I used to love brushing hair and putting the ribbons in there. Okay, and the parents go, oh my goodness, my kid doesn't look so bad. And you'll get smiles from them. Make sure that they're eating what they should. Remember, nutrition. And we take care of temperatures, not because it's a dangerous thing, but because when you have a fever, you feel horrible. get those fevers down. And when you're doing all this stuff, you are teaching parents the why. Always worry about safety. Kid has a seizure and there's toys in that bed. I'm going to make sure those toys come out. I'll throw them on the floor. I don't care. And the kid's not going to hurt himself on it, right? And I'm going to turn them to the side in case they need to vomit. Side rails up all the time. Making sure we wash hands, use masks, using the infection controls as we should. And then transporting children. We transport children in cribs, in wagons, in beds, stretchers. Just make sure it is done safely, okay? We don't restrain children that much. This little upper one here with the mother holding the child, she's holding the child to get a blood draw. That's one of my Huggies. Help us give great injections efficiently and safely. Kid's happy, you're getting your blood, the kid's safe. Couldn't be better than that. Sometimes we do have to do more than that. I think this little girl down here with the elbow thing, so she doesn't, pull on whatever she's done. Minimal restraints. Many of the times we will also not restrain, we'll just have an extra caregiver. Just know that if we need to, we do have restraints that are possible. Positioning for procedures, whether it is for a spinal tap or if it's to get an IV in, make sure you do it in an appropriate manner that you're not hurting the child. Always safety, making sure those toys are not too little and preventing falls, keeping your hand on them. Again, infection control, making sure you wash hands. Now, an infant drawing blood. Now, the only thing you do not have to draw blood, you have to do for your PT and your PTTs, bleeding coagulopathies, you have to stick a needle. But everything else we can do on a heel stick. You do it on the outer portion, make sure that lancet's not too big, and you warm it up with a hospital approved warmer because you can burn them. And if you put that down, slowly squeeze. A CBC and a chem profile is 2 tubes, 1.2 mLs of blood. It's not much at all, right? And then stools, it could be a swab, or it could just be a swab of the nose. Know what you need to do. Medications, of course, you're gonna do all the rights. Make sure that you get an older kid, tell them, do you want a pill, you want a liquid? Do you want it in a cup or a spoon? Be very direct when you're asking these things. We use all of these central lines. Ports we use a lot, that bottom left, very common for your cancer children. And they numb the area at home before they come in. They know they need blood. Nasogastric, orogastric gastrostomies. We're going to be either having the peg on the left or the other one to the right. Depends on insurances, which actually you're going to get. Remember not to pour it in all at once because it goes from nothing in the stomach to full. Do it slowly and always do an assessment before you give it. Giving it rectal, have them on their side. Make sure you push it under the sphincter with a lot of lubricating jelly and then hold the buttocks together, especially on the younger children. That works mostly with acetaminophen, right? Tylenol suppositories. There's all sorts of tubes. Make sure that you flush before, after your G tubes. And then of course, if it's a central line, again, flush before and after, always teaching the parents what you're doing as you're doing it. Otic, nasal, this is just like you saw in pharmacology. Eye drops, you pull the eye down, make sure you clean debris before from the inner to the outer canthus. And nose drops, blow the nose before we give them. Monitoring intake output. Remember I told you a diaper that's dry, it says 30 grams. If it's wet, it's 60 grams. The difference of 30 mLs is your output. Very accurate. And they've got all different things to make sure that we securely attach the IVs. Make sure that they suck a thumb. You don't use that hand if at all possible. Oxygen. Now, oxygen, we usually think adults, a nasal cannula. That tickles an infant. Plus you have to tape it on. that top picture, that oxyhood, is the most accurate and easiest tolerated for your small children. And it gives you the proper amount of oxygen. They can suck their fingers, have a pacifier, and they love it. And there's all different other sorts of things. When we have any sort of tube, and the trach tube, make sure when we suction, we don't go longer than 15 seconds. And even that's a long time. And just to clear the tube, all right? Make sure that it's patent and you have a new one at the bedside. Respiratory, we're talking aerosols and giving these children their albuterol. This little spacer that you push is great. It's a dose of 2, you put it around, 2 puffs, they breathe 3-4 times, and guess what? Works really well. And even young infants, you can do it too. Younger kids, especially your premature children that don't have in yet a G tube, they're going to do OG through the mouth, oral to the stomach, gastric, or in the nose. And that's for intermittent feeding until they get big enough to eat by themselves. And children do get enemas because children can control their stool. And they do to get some sort of, notice me, let me just hold my bowel for 7 and 10 days, they can hold it. And then if you look at the x-ray up there, it's all full of stool. Give them an enema and be prepared for a lot to come out. If it continues, of course, they'll look at giving maybe Miralax or something. So preferred IM injection on an infant is what?
D.
D.
Vastus
D.
lateralis. Yes. On adolescents, you give IM in their deltoid. I made it through, guys. Thank you for your patience. I'll be sending you the Kahoots also, which has a lot of those questions. Gianna, that baby's adorable. Beautiful.
Yeah, that's my baby boy, Nicholas. He has a little man bun.
I was going to say it needs a nice little bow in it, but I guess not. Your husband would kill me. So no. Thank you, guys. If you need to know how you did, send me a message. I'll say yes, no, or you need to see me.